All right, good morning, everybody. To those who are just logging in, welcome to our Healthier Black Elders Lunch and Learn. We will get going here in a couple of minutes. Please get yourself comfortable and situated, and we will start right at 11:05. Thank you. All right, again, good morning, everybody. We'll get started in just a minute here. Thank you very much for logging in. And just a reminder to everybody who's attending, this webinar will be recorded and we will have it posted on our Healthier Black Elders McWar site, hopefully, knock on wood, by the end of the day. So. All right, I'd say let's go live. Good morning and happy Veterans Day to all of our attendees who are with us today, who've served our country. It's an important time to remember and to honor the service for us. Thank you so much for taking time to join us for our November Lunch and Learn today on medication labeling. My name is Sean Nurick, and I'm one of the program coordinators for the Healthier Black Elders Center here in Flint. I would like to give a brief introduction of the Healthier Black Elders Center before we get going with our presentations. HBEC started in 1997 and is funded by the National Institutes of Health. The center aims to address and reduce health disparities through research and education. We do this through our research registry, where individuals learn about various social and behavioral research studies and may be invited to participate. Currently, we have 1,200 active older Black adults in the registry. We also host various events, like today, that provide health-related education to the community with a focus on aging. We provide education on topics that range from diabetes and heart health to food safety, nutrition, creating healthy habits, and brain health. Typically, we hold these events in person. Hope you're still able to enjoy the virtual format in the meantime. Hopefully 2022, knock on wood, we're going to get back to seeing all our friendly faces in person. To learn more about our program, please visit our website, and we'll make sure we put this in the chat box, www.mcwar.org. That's www.mcuaar.org. health.This.org, or you can call our office at area code 313-664-2616. For anybody that is not currently an HBEC member and would like to join, please call our office to complete a survey and get added to our mailing list. You'll then start to receive our biannual newsletter that lists program events, recruiting studies, and more health information. I'll say that website and phone number again for everybody. The website is www.mcuaar, that's MCUAAR.org, and the phone number is 313-664-2616. Before we begin with the presentations, I'd like to make a few housekeeping announcements. This presentation is in webinar format, which means that your cameras will be off and you will be muted. This webinar is being recorded and will be available to watch at a later time on our website. For those that are joining by computer, if you have a question for any of the speakers, please submit your questions in the Q&A box at any time. The Q&A button can be found at the bottom of your Zoom window. For those joining by telephone, if you have a question that does not get answered by the end of our program, please call the HBEC office and leave a message with your question. One of our staff will follow up on you. All right, so right now we have a special announcement from Ms. Joyce Blair. Ms. Blair is a counselor from the Ann Arbor Center for Independent Living. And Ms. Blair is going to speak a little bit about Medicare, Medicaid assistance, and some other topics that'll be useful to our senior populations. So Joyce, if you can go ahead, the floor is yours.
Thank you for that introduction, Sean. I am with a Center for Independent Living in Ann Arbor. We are part of a disability advocacy network nationwide. I'm also a Michigan Medicare and Medicaid Assistance Program counselor. For information about, as you all may know, we're in Medicare open enrollment, and that period occurs every year from October 15th through December 7th. So to find a Medicare counselor in your area, you would call the State Health Insurance Assistance Program, which in Michigan is MMAP. Their phone number is 800-803-7174. You will be asked for a zip code in which you're seeking a counselor, and placed on a schedule so that you can review your Medicare coverage and enroll in a plan, change your plans. There are also special enrollment periods for people that are approaching retirement age. That will depend upon when you're turning age 65, or if you are designated as a person with disability from the Social Security Administration. Our mission at the Ann Arbor Center for Independent Living is empowering the lives of people with disabilities and advocating for a more inclusive community for all. We provide peer support, independent living skills training. We help people apply for Social Security programs. We provide disability awareness trainings in the community. We partner with regional organizations to enhance and increase capacity in serving people with disability in Southeast Michigan. We have a spinal cord injury support group, in which anyone can participate that has a spinal cord injury. And I want to give you a couple of other local contacts. If you need an area agency on aging, you would call in Detroit, Detroit Area Agency on Aging at 313-444-4446. And I apologize, I don't have the number for the Flint office readily available.
That's no problem, Joyce. We'll get the Valley Area Agency on Aging phone number in the chat box here shortly.
But there's another organization that I want to inform people about, and that is Disability Network, Wayne County, Detroit. Their website is dnwayne.org. They are also our partner in Disability Network of Michigan.
Do you want to, can we ask you a question now? You want to wait till later?
It would be fine to ask a question briefly.
What do you, excuse me, what do you know about the facilities in Kalamazoo along the same lines that you have just described for Detroit?
Disability
DAAA.
Network Southwest Michigan. Mhm. And so if you just go to a website, there's a website called Disability Network Michigan. And all of the CILs or Centers for Independent Living will be listed there.
Now, you say do you work with Medicare too?
Yes, I am a certified Medicare counselor.
How does Medicare, can Medicare and Medicaid work together in the state? Or how does, is either
Yeah,
one or the other?
yes, there are people that are dual eligible for both insurance programs.
What, do you know what that eligibility is?
I am going to ask you to contact the MMAP program because I don't, right now is not a good time to go into personal reviews. So that MMAP number that was provided, 800-803-7174, someone can review a particular case for eligibility for what's called a low income subsidy. And we would be happy to do that on a more personal level.
But can you give me that number again, please?
800-803-7174. And again, the website is MMAP Inc., MMAPINC.org.
All right.
Okay,
well,
thank you. Thank you.
Thank you, Joyce.
You're very welcome.
Thank you for the announcement here.
Yep.
And we're gonna move on with our presentation. So
Thank you.
all right. In the recent months, we have introduced a newer segment for our Lunch and Learn series called Critical Crossroads. This is coming up on the wrong window on my screen here. All right. So today's Critical Crossroads segment will be presented by Detroit HBEC cab member, Mr. James Bridgeforth. So Mr. Bridgeforth, what can you tell us about legislation in Washington, D.C. right now?
Well, Sean, what I'm going to do first of all is I'm going to address three bills rather quickly. We're going to start out with where they were and where they are now. The first bill we're going to talk about is going to be the HR 1 for the People's Act of 2019. And so I think we got some information there on the screen. And basically, this bill addresses the voter access, election integrity, election security, political spending, and ethics for all three branches of the government. It provides for the states to establish independent, nonpartisan redistricting. It addresses campaign spending, including expansion of the ban on foreign national contributions, spending on campaign election, expanding disclosure rules related to organizational spending, and requires candidates, president to and vice president to submit 10 years of tax return. Now, this bill is currently held up in the Senate because, number one, because of the filibuster. The Republicans have said that they were not going to support this bill, and Mitch McConnell has made it a statement that he and his caucus will not support anything to do with this bill. So the only chance this bill has of passing is passing by way of eliminating the filibuster. And so that's going to be up to the Democrats. And right now, Joe Manchin, Kristen Sinema of Arizona, Manchin of West Virginia, they are not in favor of getting rid of the filibuster. So, and in a sense, it makes sense because their idea is that if the Republicans get in office, then they can do the same thing with any bill they want to pass. So we'll see how that goes. But right now, it's stalled. The second bill that I'm going to talk about is the John Lewis Voting Rights Advancement Act. Now, prior to this first act, this bill passed back in 1965, along with the Voting Rights Act. Subsequent to the passing of that bill, there was a case brought against the Attorney General And the Supreme Court ruled that this features of this bill were too broad. And so in essence, it gutted the primary emphasis on this bill, and that is to make sure that before states change their voting rights and voting procedures, particularly those who had a history of discrimination, that they would go and get clearance from the federal government to enact these changes. So, this bill provided tools to address discrimination practice and to seek protection for all Americans' right to vote. It created a new formula for coverage that applied to all states and hinges on finding of repeated voter rights violations. So anyway, the Supreme Court gutted that, and in so doing, it stated that, again, as I said, it was too broad and discriminatory. Fortunately, the Supreme Court decision was limited in scope and recommended that Congress create a new formula, and the John R. Lewis advancement does just that. It's an attempt to rectify the decision that the Supreme Court made, gutting this bill. And right now, as you can see across the country, as a result of not having this protection, states are enacting all kinds of voter restriction laws to prevent minorities from voting, particularly after the 2020 law. So right now, these bills are stalled in Congress, and Mitch McConnell, matter of fact, they tried to have a vote back in October, I think about November 6th, November 3rd. And the Republicans would not even allow them to bring this bill up for a vote. So anyway, that's where we are on those bills. They are stalled, and they're working now to try to work through those bills. Also, the fear is that on the Republican side, according to Mitch McConnell, the bill gives too much authority to the federal government to control the elections at the state level. And so, but the real reason is that they fear that after the 2020 election, that all of these people are going to vote and they're not going to get back in power. And also they want to stall Joe Biden's agenda so that come 2022, they will have set up the situation so that Republicans have a better chance of taking back the House and the Senate. So that's basically, in a nutshell, what those two bills are. Now I'll move on to the infrastructure bill. The original infrastructure bill, there were two parts of it. One had to do with the actual infrastructure, and the other had to do with what they call, I'll call it the social agenda. And in the original bill, the objection to the bill were, and this is Manchin and Sinema, that the bill was too high. Manchin did not like the climate-related part of the bill that provided cash incentives for clean energy, electric cars, and which are negatively affected the coal industry, which he has business with. Sinema objected to the expansion of Medicare to include dental, vision, hearing, AIDS, Medicare, medical negotiation for drugs, Medicare negotiation for drugs, 12-week family leave, and also Manchin opposed the child tax credit without a work provision. So right now, this bill is also in the House. So what did pass was the actual infrastructure bill. And this bill on November 6th, the infrastructure bill was passed and sent to the president for his signature. And so this bill contains the following. It was $1.2 trillion infrastructure bill. And it contains, and I'll just run through this rather quickly. There was $110 billion for highway, bridges, and roads, $39 billion for public transit, $66 billion for rail service improvement, $7.5 billion for electric vehicles, charging stations, and converting school buses to electric and hybrids, $65 billion to modernize the electric grid, 25 billion to make improvements to airports, gates, taxiways, and terminals, 55 billion for wastewater and water treatment, including 15 billion to replace lead pipes, 10 billion to address water contaminations, 6.5 billion for broadband improvements to improve service to rural areas, low-income families, and tribal communities. So the bill is to be paid for by tapping into $210 billion unspent COVID-19 fund, $53 billion in unused unemployment fund, and various other available funds. Now, so that is the infrastructure bill. Now, getting back to the what I call the Build Back Better social bill. Again, as I said, this bill originally, these two bills were designed, at least from the House side, to pass together, and there were a lot of discussion and resistance from the progressive Democrats in the House to passage of this bare infrastructure bill because they wanted the social or the part Build Back Better social aspect of this bill to pass also. But negotiations came down to, okay, we got to pass something. So what we'll do is we'll pass the infrastructure bill, pure infrastructure bill. Then what we will do is we'll come back to and look at the what I call the social aspect of this bill. And I was listening to Representative Jai Paul talk on Rachel Maddow the other night, and she feels very certain that they have a commitment to pass this bill sometime next week. And the thing that's holding it up from the centrist Democrats' point of view is the cost of the bill. So they're waiting now for the budget office to score this bill and to make sure that the bill coincides with, and cost-wise, coincide with the price that the Biden administration has outlined. So once that is determined, the bill will pass, go through the Senate, and be sent back to the House. Go through the House and be sent back to the Senate. Now, in the Senate, the problem there is going to be whether or not they can get this bill passed through reconciliation. Now, my understanding of this is that any bill that deals with money, they can pass it on the basis of reconciliation. So this is where those bills stand right now. So that's, now the other thing about these bills, the Manchin and they objected to raising taxes on the rich. So we'll see how that plays out. But basically, that's the status of these bills, and that's my presentation in a nutshell. Are you there, Sean?
All right, I am there. Thank you, Mr. Bridgeforth. We appreciate you giving everybody an update on this important legislation. So, all right, now we're gonna move on to our main presentation. Our featured speaker, Dr. Laura Bix, is unable to join us today due to an emergency. So, if possible, please take a moment to keep her in her thoughts.
John, can I add one other thing?
Yes, sir. Go ahead, Mr. Bridgeforth.
One of the things that's complicating these bills is that if you take the Arizona population, there are 7,152,000 people in Arizona. The white population make up 82% of the population, and blacks represent only 5.2%, and Asian 3.7%, and Hispanic 31.7%. And you got some of the same kind of representation, I think, in West Virginia. The minority population, including Asians, African American, Hispanics, and all of those, make up less than 4% of the population. So you can begin to see how the balance of power or push against the legislator is sort of out of balance if you look at the whole voting power of the community. So I just wanted to add that as something that says, what is the incentive to vote for some of these voting right bills? So anyway, I just want to throw that out.
All right.
Thank you.
Thank you. Thank you, Budge. All right. So yeah, our featured speaker, Dr. Bix, is not able to be here today. But fortunately, we've got pretty strong pinch hitters to come in here. So we're fortunate to be able to introduce Dr. Mark Becker and research assistant Krishna Venkatesan. Dr. Becker is a professor and the associate chair and director of undergraduate education in the Department of Psychology at Michigan State University. Dr. Becker was co-investigator on the medication label study with Dr. Bix. He leads the attention and perception lab in the cognition and cognitive neuroscience program within the department. His lab performs basic research on the allocation of visual attention and studies how attention influences information processing. The lab also engages in applied work, working with an interdisciplinary group that applies methods and theory from basic research in visual cognition to the design and evaluation of product labels that garner attention to critical information. And the lab also investigates how basic research can be leveraged to improve the detection of rare targets in real-world visual search contexts, such as in baggage screening or radiology. Krishna completed his MS in packaging science last year and has a BE in printing. He's currently pursuing a PhD in packaging at Michigan State University, and his interests include studying the effects of label designs on over-the-counter drug decisions, which will be the topic of his dissertation. So let's give Mark and Krishna a warm welcome and a big thanks for pinch hitting and sharing this information today. All right, Dr. Becker, if you want to go ahead and share your screen, go ahead and take it away.
All right, I believe I'm sharing. Are you seeing that?
Yes, sir.
All right. So thank you for that introduction. I would just like to add another graduate student, Andrew Rodriguez, is here today and is part of this project. Andrew is in the psychology department. So we have one graduate student from packaging and one from psychology that are working on this project together under Dr. Bix and I. And so basically, yes, Dr. Bix was going to give this, but an emergency came up. So I'm the backup quarterback who's being thrown in to save the game at the last minute, but hopefully I will not disappoint. So what I'd like to talk to you today about is some of our work trying to optimize over-the-counter medication labels for use by older adults. And before I get into that, just a few disclosures. Our team has had previous funding from the Consumer Healthcare Products Association to develop the pilot data for this project. We've also received funding from the Pearl J. Ulrich Endowment and Aging related research, and from MSU's Clinical and Translational Science Institute. Currently, we're funded by the Agency for Healthcare Research and Quality, and so they're funding this research currently. In addition, Laura Bix has served as a plaintiff in expert cases involving warnings for various product types, including drugs. And I should also acknowledge, in addition to the graduate students who are currently here, Krishna and Andrew, Alyssa Harbin worked on this work in the past and has since gotten her PhD and moved on. And we also work with pharmacists at University of Wisconsin, Beth Martin and Robert Breslow. Having gotten all that out of the way, here's what I hope to cover today. So my objectives are to introduce you to the mission of our research team and some of the work we've done. And in doing so, I hope to introduce a model developed by our team that takes from cognitive psychology and kind of applies it to the design of more effective product packaging. And so I'll introduce that model and talk a little bit about how it guides our thinking on this. And then I'll provide an overview and some background about research investigating OTC labels that are designed to work better for older adults. And by work better, what I mean is that allow older adults to make safer, more effective product decisions. So to start, just a little bit of background here on the evolution of the design of healthcare products. So there are two kind of approaches to design. One is a product-centered design, and the other is a user-centered design. And in the product-centered design, which was kind of the traditional approach that people used, the properties of the product determine which users can use it. And so really that approach focused on what is this medication, what is this product, and what information does this product have to have because it's this product? And so the focus was really on the qualities of the product itself, without a whole lot of concern about, well, who needs to use that information and how can we present that information in a way that allows the person who needs to use it to use that information effectively. With the kind of evolution of thought and product design, people started to take into account, well, who's going to need this information and can we present it in a way that's better able for people to interact with it, the people who need to. And that's a user-centered design. And there the focus is based on the user's needs and the user's capabilities. What are their strengths? Can you present information in a way that allows users to more easily use the information they need? And so in our lab, what we've been doing is considering both. So consider both product-centered and user-centered designs to create products that are safer and perform in all contexts of healthcare. And just to make this clear, when I say we use both, in terms of the product-centered aspect of that, it's essential for each product to identify what are the critical pieces of information that somebody needs from that product in order to use it safely. And so that's centered on the product. But then the user-centered part of the design is, well, how can we present that information in a way that most users will be able to easily, clearly get that critical information? So we try to design good products, but then we also try to objectively test that the products are actually communicating the information they need to communicate for the safe and effective use of those products. So in short, we focus on ways to present critical product label information in an effective way. And in order to do that, we're really guided by this model, this human package interaction model that we developed, was developed in actually Laura's lab, that borrows from cognition and looks at the stages of cognition necessary for people to effectively interact with information. And so in order for a message on a label to be effective, first, the person has to be exposed to it. The information has to be on the label in order for it to have a possibility of impacting people. But in addition to that, the information has to be perceived. That is, the participant or the patient needs to actually look at that information. And then, having looked at it, they need to encode that information, which is they need to attend to it and process that information into what we call their working memory, or into kind of their conscious experience. In addition, that information needs to be comprehended. So you have to understand what the message is, and then it needs to be executed on. You need to take that information into account and allow it to affect your behavior. And in terms of these steps of processing, they build on one another. That is, you can't have comprehension till after you've had exposure, perception, and encoding. If you never get exposure or never get perception, you'll never get comprehension. The whole process will be derailed early in that cognitive process. So that's kind of the heart of our thinking, is this cognitive model of information processing. But within that, there are also various factors that influence this process. So the task at hand, what is the participant or patient trying to accomplish? Individual differences in the consumers or patients. What are their life experiences? What are their cognitive capacities? All sorts of factors that can influence how this process plays out. The context in which the task is occurring can influence processing, and the product package design can. And our focus is really on considering all these other factors and how they influence cognition, but then designing products to help across these various contexts, consumers, and tasks present information that's effective. And it really is a process. You have a task at hand that interacts with the package that also interacts with people's cognitive processing to produce some type of output or execution, a motor response, a decision that produces some effect. As applied to medications, the task might be, is this a safe medication for me to use? The patient interacts with the package to try to figure out whether that's safe or not, goes through these stages of cognition, and then produces some type of motor or output response. They either purchase it or they don't, and then that has some effect that can either be beneficial if they've chosen wisely, or might have negative effects if they've chosen a medication that's not effective or safe for them. So just to give you some background, most research on label designs who are looking at ways of improving labels and are focused on kind of user-focused design have used focus groups and surveys to identify label techniques that would be effective. And so typically what that research does is it has a couple different designs, and then they ask people to attend to specific information. And then they assess how well those different designs lead to comprehension of the message. So you might have different ways of presenting warnings, and you get a focus group together and you ask them, what do you think this warning means? What do you think this warning means? And see which method of presenting that information leads to better comprehension. And that's important. But if you look at kind of the model of cognition, comprehension is a relatively late process. And by putting people in these focus groups and asking them specifically, hey, what does this particular thing mean? You bypass whether on a package that would ever attract attention. Would people ever perceive it and encode it? So you're only focusing on this relatively late process in this stage of processing, ignoring that the labels also must lead to perception and encoding. In addition, these are subjective measures. You have people saying, yeah, I think that one would work better, which may or may not actually be accurate when you look at how the products perform in the real world. So kind of using this model and looking at what people have done before, we can identify some gaps, needs, and then come up with some tools to address them. So as I was saying, in the past, there's been a tendency to assess comprehension, this relatively late stage of the cognitive process, without looking at whether people are ever attending to that information. And without attending to it, you're not going to get to the comprehension stage. So we need to consider ways to design labels that drive attention to information that's critical for the safe and effective use. And then rather than rely simply on subjective reports of, yeah, I think I'd attend to that, we need to objectively measure whether the manipulations we're doing are actually changing attention and whether that's actually changing behavior, changing and improving people's responses or their selections. So our approach starts with identifying what information is critical in a given package for its safe use. And then we test novel label designs that encourage attention to that critical information, and then use objective measures to investigate attention to that information and appropriate use of that information. So that's kind of the framework that we apply in this work. And we've done it in a number of contexts. So just to give you some background, we've done this with medical devices. Most of this work has looked at surgical technicians' ability to select an appropriate medical device for a given patient. So for instance, if you have a patient who has an allergy to latex, can we label medical devices better so that surgical techs can quickly find a latex-free device when they're working with a patient? We've also done it with food and alcohol labeling, with food labeling focusing on getting critical nutrition information to people in a way that they attend to it and understand it readily. And in alcohol, we've been focusing on the fact that most government recommendations are based on standard drinks, but the labeling of alcohol content is alcohol by volume, and there's a disconnect between standard drinks and that alcohol by volume. So we've been trying to present different ways of presenting alcohol by volume, but that's closer to the standard drink recommendations from government agencies. And we've also done a lot of work on drug products, trying to improve drug errors that pharmacists make when they mix up names of look-alike, sound-alike drug names, but also trying to get people to attend to the most critical information and warnings on medications. And really, that's what I want to focus on today. And specifically, I want to focus on over-the-counter medications, or OTCs. And over-the-counter medications come with a lot of benefits. So there's a lot of benefits to self-medicating. And if you're interested, the Consumer Healthcare Products Association has a website with a lot of the statistics on just how many benefits there are and how frequently people are using over-the-counter medications. But some of the benefits are they provide flexibility, independence. You can go to the pharmacist and get your own medications without having to schedule a doctor's appointment. That leads to higher access. You can, if you go to Meijer, you can get your over-the-counter medications 24 hours a day, 7 days a week. It increases privacy because this can be done in your own home without getting other people involved. It also increases affordability. It's been estimated that over-the-counter drug use saves about $77 billion annually in avoided clinical costs, that is in doctor visits, and about $25 billion in drug costs, because typically once something goes to over-the-counter, they lower the price relative to prescription drugs. In addition, over-the-counter medications are seen as the first line of defense. That is, 80% of consumers prefer to use an over-the-counter medicine to try to address ailments prior to seeing a doctor. And if you can effectively treat yourself without having to go to the doctor's office, again, that's going to save money and time. And even 75% of primary care physicians recommend starting with an over-the-counter medication prior to moving to a prescription medication. So in general, there are many benefits to over-the-counter medications. And those many benefits lead to high usage. So US consumers make about 26 trips a year to purchase OTC medications, but they only visit doctors on average 3 times a year. So we're really doing a lot more with over-the-counter than prescription drugs. 70 to 90% of all illnesses have been estimated to be addressed with self-treatment with over-the-counter medications. And the availability of over-the-counter medicines, the fact that they can be bought off the shelf without a prescription, provides symptomatic relief for an estimated 60 million people who would otherwise not seek treatment. That is, if their choice was go to the doctor or do nothing, they do nothing. But with OTCs, they have a way to treat themselves without that extra burden and cost of going to a doctor. So in general, the benefits are numerous. However, one thing that tends to get lost a little is that there are potential risks associated with OTC use, using over-the-counter drugs. And those risks are kind of under the umbrella term of adverse drug reactions, which are unintended harmful events attributed to the use of medicines. And over-the-counter medications are associated with a significant risk for adverse drug reactions. And those risks come in multiple forms. So one is dose-related risks. So for instance, 24% of participants took more than the recommended maximum dose of over-the-counter medicines. And in the medical field, that that's not good in that, if you increase the dose too high, you don't get any additional therapeutic benefit, but you raise the risk of having adverse drug reactions. A third of people using over-the-counter medications struggle with dose timing. You're supposed to kind of take these on a relatively predictable schedule to maintain an even amount of the medications in your system, and people have difficulty with that. And 46% of participants used multiple products with the same active ingredient. And if you're using multiple products, they may have different product names, but if their active ingredient is the same, that's leading to these risks of increasing above the maximum for that one active ingredient. So those are dose-related concerns, but there are also increased risks that are relatively selective for older adults, or at least show up much more readily in older adults. So it turns out that 96% of people 65 and older report using OTCs, and that group of 65 and older consumers consume about 30% of all the OTCs consumed in the US, despite comprising only 13% of the population. So it's a group that's relying heavily on OTCs. And older adults are at risk, higher risk of having an adverse drug reaction for various reasons, including changes in the pharmacokinetics, that's how the drug interacts and is metabolized by the body, changes in perception, cognition. A big one is the likelihood of taking multiple drugs, or this propensity for polypharmacy. That just means taking multiple drugs concurrently, and a greater risk for low health literacy. And on that polypharmacy, the idea of taking multiple drugs, that is a really serious issue here, because 25% of older adults take a combination of 10 or more over-the-counter and prescription medications daily, which is troubling given that research suggests that the likelihood of having an adverse drug reaction is 10% if you're only taking a single medication, but it jumps to 75% for people who consume 5 or more medications concurrently, and a quarter of the older population is taking twice that amount, suggesting that there are real risks for having drug complications from taking many different, both prescription and then mixing them with over-the-counter medications. If you put all this together, there are significant costs here, significant risk here. It's been estimated that about 3 to 7% of all hospital administrations in the US are for adverse drug reactions. And a meta-analysis suggested that about 106,000 deaths in the US annually are attributable to adverse drug reactions. The bottom line is people tend to think medications are, particularly over-the-counter medications, are really safe, but occasionally that is not true, and it's often not true when people start to take many, many medications daily. So the bottom line is it's essential that individuals understand the nature of OTC medicines, the consequences, and the benefits of complying with warnings and information about those OTCs. Now, the problem is, well, that leads to a situation where effective labeling is really critical, particularly for over-the-counter medications, because there's not a prescribing doctor who's saying, oh, take this. It's up to the individual to determine what they're going to take. And often the pharmacist isn't involved. People just walk up to the shelf and grab what they want. So there's no kind of learned intermediary, a doctor or a pharmacist that's ensuring safe usage. It really puts the burden on ensuring that on the consumer themselves, and the way the consumer can get that information about what's safe is really through those labels. So it is an area where effective labeling is important. And so that's what we've been working on, is trying to make those labels work better for safety. And we've used 2 approaches to improve labeling for healthcare products. One is to improve on the current approach, to improve on current labels. And the second, which I'll talk about briefly at the end, is something relatively new we're looking into that leverages technology to kind of shift the paradigm away from traditional labeling. But starting with improving the current, the first step we need to do in this work is to identify what is the most important information on product labels, OTC labels, to reduce adverse drug reactions in older adults. And to identify that information, what we did was we ran a survey of experts, in this case, 318 practicing pharmacists. And what we asked those pharmacists to do was evaluate which of the required information that's required by law to be on a over-the-counter medication was most important for the reduction in adverse drug reactions among older adults. And the way we did this was, it turns out that there are 8 types of information that the regulations say have to be on an over-the-counter medication package. And we asked first the pharmacists to rank order those 8 sections, which are active ingredients, purpose, uses, warnings, directions, other information, inactive ingredients, and questions or comments. And it turned out that 3 of those 8 were seen as really important for safe usage at the time of purchase. And again, context matters. We were particularly interested in time of purchase. And at time of purchase, that the things that are important are the active ingredient, purposes, and warnings. If you switch and ask them at the time of administration, directions become important as well. So it does change a little depending on when you're talking about purchasing or taking the medication. But at the time of purchasing, the 3 important were people should pay attention to the active ingredient, the purpose, and the warnings. Now, we're trying to develop ways to improve attention to that critical information. And in order to do that, we're hopeful that we would find that from all this information, we can focus on just a little bit of information and drive people's attention to that little bit of critical information. And if we look at active ingredients, purposes, and warning, active ingredients are pretty small. They're pretty direct. It's ibuprofen at 200 milligrams. The active ingredient information is important, but relatively finite, relatively small chunks of information. Similarly, the purposes are relatively straightforward and small typically. But the warnings are huge. This whole section is all warnings. And so if we're trying to, drive people's attention to a subset of really critical information, this is a lot of information to try to get people to attend to. Fortunately for us, it also turns out that in terms of these warnings, the regulations stipulate 13 different types of information that should be in the warning section of a label. And we also had our pharmacists rank order how important each of those 13 types of warnings were to the reduction in adverse drug reactions in older adults. And 2 of them popped up as being really important, with the rest being seen as important by less than 50% of pharmacists, and some of them being seen as important by almost nobody. And so using experts, we were able to identify that there are really 2 types of warnings from all that warning information that is most critical for people to pay attention to. And those ended up being the do not use this product warning. So do not use if you have recently had heart surgery type of warning, or ask a doctor or pharmacist before use if you have some diagnosis or if you are experiencing some type of medical issue.
Mark?
Yep.
I'm going to have to leave this. I had something that come up unexpectedly, and I'm assuming that we'll have a record of your presentation that I can look at later.
Yep, it's being recorded.
Yeah, I just wanted to let you know that I had something came up and I'm going to have to leave.
Okay.
So I appreciate the information, and thank you very much. Okay.
Okay, thank you.
Okay, thank you.
Bye-bye. But basically the two things that become important are the drug or drug diagnosis warnings, which allows us to focus in on those as something to try to drive people's attention to. So having established that, the second step was to objectively evaluate which information people pay attention to. And so some of our early eye tracking work here that led up to this use eye tracking as an index of attention. And eye tracking is a good index of attention that gives you good kind of objective measures of what people are attending to. Because using an eye tracker, we can tell in real time what information people are looking at as they interact with drug packages. And we can identify areas of interest. So that's regions of the label that contain different types of information. So for instance, an area of information might be the warning labels, or the drug diagnosis warning labels, or the active ingredient. And we can identify those as areas of interest. And then using eye movement data, we can see how long did people look at those different areas? When did they look at them in kind of sequence to get an idea how prioritized that information was for attention? How often they looked at those areas, and the proportion of respondents who looked at them at all. So we can get really objective data on how people are attending to packages that help us determine whether our manipulations are improving attention to critical information. Some of the early work we did on this before the project we're doing now used eye tracking to demonstrate that, well, what I'm showing here is the proportion of subjects that failed to ever look at different types of information. And most people looked at the brand name. A decent number looked at the drug facts panel, but there were two warnings on these packages: a child-resistant warning, so products without child-resistant closures have a warning that says you shouldn't have this in a home with small children. Almost nobody looked at that warning. And a tamper evidence warning, something like don't use this product if the foil has been broken. Almost nobody looks at that warning, despite the fact that those warnings are by law supposed to be obvious and conspicuous. If you look at the time people spend on each type of information, they spend almost all their time on the brand name, very little time on things like warnings and drug facts. Similarly, another graduate student's work had eye tracked people while they looked at a package like this, identified various zones of interest, like the brand name, the strength, the product benefit, in this case, non-drowsy, the net contents, and this warning. This happens to be one of those child tamper warnings. And again, using eye movements, you can see that the amount of time people spent was almost all their time was on the brand name. Very little time spent looking at the warning or strength. And if you look at just how often they looked at things, again, they look at the brand name a ton, but almost never look at the warnings or the net contents. And so we can get objective views about what people are doing with packages as they exist now, as a benchmark for can we change that behavior. But the take home of that early work was that people are not attending to warnings, even though the regulations require them to be conspicuous. And people are mostly attending the brand names. So switching gears slightly, I want to now talk about the pilot work related to the current experiments we're doing, where we're now trying to change people's attentive behavior and improve their responding. But to start with, we wanted to see how people were performing with standard labels. So we had subjects come into our lab and we took subjects' health histories to get an idea of what their current health situations were, and then had them evaluate various over-the-counter medications to evaluate whether that particular medication would be appropriate for the subject to take or not, given their current health. And so what this looked like was we brought people in, we showed them different medications that they could switch to different sides of the medication to look at for different information, and we tracked their eye movements while they did so. And we presented them with various different types of medications. Our eye tracker is a table-mounted eye tracker, so it just sits on the table and is really unobtrusive, but allows us to see where they're looking in real time and assess what information they look to when they're making the decision about whether this drug is appropriate for them or not. And again, we can identify areas of interest and look at how often do they look at it, how much time do they spend, etc., on those various areas of interest. Now, the key findings from this, well, before I get to key findings, let me say a little bit about the sample. So we got volunteers for this. Our sample ended up being about 2 to 1 females to males, and that's a problem we often run into. It turns out females are far more likely to volunteer or to volunteer to come into the lab and participate. So we're always trying to get more males to participate. So anybody who's got ideas on how to motivate men to participate, we'd love to hear it. But we did review their health information, and that included having them bring all their prescription and over-the-counter medicines in so we could make sure we knew what they were taking and how much. And just to give you an idea, 93%, these were older adults, 65 and older, and 93% brought at least one prescription drug, and 97% brought at least one over-the-counter medication, and over 50% brought 5 or more unique prescription drugs. So they were on 5 or more at once, and over 40% brought 5 or more over-the-counter drugs, suggesting that they were taking 5 or more of those at once. Again, highlighting that, especially among this older population, there's a lot of polypharmacy, a lot of multiple drug taking, which is a risk factor for having ADRs. So some key attentional results. So the eye tracking information that gives us an index on attention. Well, over 62% of the participants never looked at the critical information. And what I mean by that is we had them evaluate 27 packages, and they never looked at the critical information that would have told them whether it was safe for them. And so they just weren't attending to the information that would have supported good decision making. Only 9% of participants looked at that critical information on all 27 trials, and 29% what we looked at is we took their medical histories and we sent it to University of Wisconsin and said, for this particular participant, should they said this drug was appropriate or not? And there were, across the drugs and across our participants, there were 334 times and that's the expert saying, no, you shouldn't take this. And then we looked at those 334 cases and said, well, how many times did the participant say, yeah, I shouldn't take this medicine? And only 16% of the time, when the expert said, look, given your health, you shouldn't take this, did the consumer, the participant, say, yeah, this would be unsafe for me. 38% of the time, they said, nope, it's safe for me, even though it's not. And another 46% of the time, we gave them a bailout of saying, maybe, I'm not sure. And 46% of the time, they said, I'm not sure. But that means, what, over 80% of the time, when they shouldn't take this drug, they were either saying, yeah, it's safe for me, or they weren't sure, which is troubling. And so the take home is, from that early work, is people aren't looking at critical safety information. And as a result, people are making unsafe medical decisions on these over-the-counter medicines. And so our current work leveraged that, and that's our current grant. And we leveraged prior work that we had done, particularly in nutritional labeling, to try to create over-the-counter drug labels that increase attention to critical information. And then we examine how those label treatments influence attention to and the usability of that critical information. And when I say attention to, again, we're tracking eye movements as a way to index what people are paying attention to in an objective way. And when I'm talking about how well people are using the critical information, we're looking at their ability to correctly decide whether a medication is safe for them or not. And so to give you kind of an idea, and I'm going to be clear here that I'm not going to give you the specific manipulations we're doing, because our hope is to be able to run this on participants in the region. And I don't want to kind of bias our results by telling you exactly what we're doing to try to increase attention, but I'm going to give you an overview of kind of what's involved in this type of work. So the first thing that happens is when a participant shows up to participate, we characterize that subject or patient's medical history. We also do some characterization of their visual acuity. How well can they see? Because if you can't see well, that might influence how well you can interact with labels. We take some measure of health literacy to see whether the manipulations we're doing are having a similar outcome for people who are high and low in health literacy, because ideally the label format will allow people on both ends of that spectrum to do well. We then have subjects fill out a brief health survey. We then have a guided health history interview to make sure we're not missing anything. And we also log all the medications that the participant uses. And we have this kind of cool device where we can they bring in their actual pill bottles, and we can put them in this scanner that actually scans the individual medication and gets accurate information on what's in that medication, but also de-identifies it. So we type in their name when we're running this, and it takes their name out of the scan and replaces it with a numerical code so that all the health information is de-identified from individual subjects, from the subject's identity. So that's kind of step one, characterizing the participants. And then in step two, we test the design. So we have people look at various products that have different label designs, the designs we've created, and we track their eye gaze while evaluating whether medications are appropriate for them, different medications with different label designs. And we record the participant's judgment about appropriateness. Is this appropriate for you or not? And that's what the subject does. And that all takes about an hour, less than an hour and a half. Once the subject leaves, we continue on. So we again send the health history information and the medication information that's been de-identified to the University of Wisconsin, to our pharmacist team there, to have them evaluate for a given participant where they should have, which drugs they should have said were inappropriate for them and which drugs were appropriate from them. So while we might not get along when we play sports against each other, we get along when we're doing science. But they provide us with what the correct answer was for each participant for each drug. And we use that information and our eye tracking information to then do statistical analyses, where we look at how the different label designs affect performance, your ability to correctly say this is safe or not safe. And we also look at whether the reason the label designs might impact performance is because they change attention. They increase attention to critical information, which then impacts performance. And our belief is that with careful design and objective measures of performance, we can create better labels. Labels that encourage attention to critical information, and labels that are easier to use and promote better decision making. And we've done about half of the studies in this set of studies that we're doing on this. And so far, our results are encouraging. We are able to increase attention and allow people to make better, faster, more accurate decisions. But we still have to do these eye tracking experiments to look at it in a more natural context. However, in doing this research, we realized that even with an ideal label, there are challenges. So there's human error. So people still need to make good decisions. And in order to do so, they need to know and remember what active ingredients they currently take, all their diagnoses, and need to comprehend that information and then compare it to the information on the label. So there's ability for human error, even with an ideal label. And there are issues associated with just how labels work. Because the way a label works, to find an appropriate over-the-counter medication requires you to search for the absence of information. And what I mean by that is, if I have diabetes, I'm looking for an over-the-counter medication with no warnings about diabetes. So I got to look through everything to see if it's anywhere. I'm looking for the absence of information, the fact that there's no warning. And there's a lot of data from visual cognition work that suggests that the search for the absence of information is problematic. Those searches are slow and inaccurate. And so the way labels are, even an ideal label is designed, there still may be some issues with health and safety, which has led to our new approach. And this is brand new. We're just developing kind of proof of concept of this, but we're leveraging technology to assist the human. And just briefly, what this looks like is we're taking a data management system that we're putting patient health history data into. So all the diagnoses, medications that a patient has go into this. We also get a drug facts database, which is available from the FDA, that has all the contraindications of drugs with other drugs and drugs with diagnoses. And so we load that all into a database system. And then we have augmented reality. So we're taking people's cell phones and using the camera on the cell phone and object recognition paradigms so that you can hold your camera up to a medication and it can identify that medication and then compare it to your health history through this drug facts database and tell you whether that particular medication would be safe for you to use or not. So kind of helping the consumer by making a bunch of those decisions for them. Now, it does require putting in the correct history, but once that history is in there, using kind of object recognition software, we have built a proof of concept of this, which I will just show you here. So this is a cell phone being held in front of a number of packages that have been associated with a health history so that some of them are safe, some of them are not. And as you hold the camera, the cell phone up, it tells you with like a green check that NyQuil is safe for this particular patient. Advil is definitely not. And these other two that have kind of yellowish exclamation points, that means it may or may not be, but you should check with the pharmacist before you buy them. And we think that in the future, again, this is brand new, but we think in the future, developing systems like this to help people make decisions might be terribly effective. And so that's my presentation for the day. I thank you all for listening. If you have questions or concerns, there's my contact information, my co-investigator, Laura, and I've also given you Krishna's contact information.
Dr. Becker, that was incredibly interesting. I think it's really important for everybody that we work with to understand that health research is sometimes so much more than a survey or experimental experimental drug studies. So I've got a question for you here.
Yeah.
Once you have a determination, you publish on it, say, hey, this is what I'm going to do to change this bottle of ibuprofen. How long will it take for the drug manufacturers to make those changes and for consumers to see it on the market?
So that is an excellent question. And the truth, at the beginning, we talked about kind of these legislative things that are stalled. The truth of the matter is manufacturers probably don't want to do this because it cuts into their profits, right? They have to redesign their packaging. It takes space away from their branding. If what we're proposing, and I know I didn't show you the details, but what we're proposing will cut into some of their space to be able to do kind of fancy branding. They're not going to like it. That said, the FDA is currently very serious about addressing this issue. They've acknowledged that it's an issue, and they're looking at ways to mitigate the problem. And so we were invited, Laura and I, this summer to a panel for the FDA that is looking into ways of trying to address this issue. So it is a bit of an uphill battle, but we hope that we will be able to provide them good information. So as they're making those decisions about how to change these label requirements, we can provide them with good information that will help them do so in a way that's actually beneficial. How long that'll act, like, I can't give you the exact months, but it is an uphill struggle. But the best we can do is, you know, right now there isn't the information to make those good decisions. And so we're hopeful to provide that information, and we have been providing that information directly to the FDA to hope to change the regulations, because really the way to get the manufacturers to change is actually to change regulation.
Right.
Now, luckily, you know, this is the FDA, not the Senate. So we
Very
might
good.
get better movement.
All right. If anybody in the audience has any questions, feel free to put them in the chat or the Q&A. We've had a few that have come through and have been answered. But I think the ultimate take home for everybody who's on this call and who will see this video is take a little bit of extra time to take a look at your labels, really read it. And if you have questions, make sure you work with your health team, your physician, your pharmacist, to make sure that you're doing right by yourself.
Right. And can I just say that, like, you know, if there were a couple take homes just to help people that I hope people would get out of this. One, it's don't assume all OTCs are safe. The second is make sure you know what the active ingredients in things you're taking every day are. If you're on a kind of a maintenance routine where you're taking something every day, know what the active ingredient is. And if you go to the store to get an over-the-counter, check the active ingredient and make sure it's not something you're already taking. Because that's where people overdose. And then the last is, look at the warnings. They're on the side of the box, but there are a lot of them. And unfortunately, the way the label is right now, there are a lot of them. But I would say really look for that do not use warning, and that ask a doctor or pharmacist before using warning are the most likely to cause problems, according to our experts.
All right, very good. Thank you so much for the presentation. I found that to be incredibly fascinating, and hopefully everybody else thought it was quite enlightening as well.
And the one last thing I'll say is,
sure,
if you're in doubt and you're in the pharmacy, talk to the pharmacists. They are there for that reason, and people underutilize them. So if you have any doubt that, like, is this safe for me, given that I have, you know, whatever conditions you might have, you know, grab the bottle off the shelf and then go up to the pharmacist in the back and say, hey, I've got this. Is this particular medicine safe for me? And the pharmacist should know.
Yep. And Ms. Stringer put in the comments here, if an OTC drug is effective, there is a possibility for adverse drug reactions. I think you would agree with that statement.
Yeah. No, you know, it depends, but yes, the fact that it's effective means it's doing something. And if you're taking a lot of it because you've already taken some in your other medications, you may be overdoing it.
Sure. Well, excellent. Thank you again. We really appreciate that. Again, today's presentation has been recorded, and we will make sure that we upload the Lunch and Learn recordings to our website as soon as we are able to do so. If there's anybody in the audience that's not a member of the HBEC program and would like to join, we could sign you up over the phone. So please give us a call at 313-664-2216. When you become an HBEC member, you'll receive our biannual newsletter, learn about upcoming research studies or current research studies, and learn about the future programs that we're going to be hosting, like the one today. So thank you again for everybody for attending. Please stay safe. We'll see you next month at our Lunch and Learn. That's going to discuss the opioid crisis and continue discussion about the misuse of prescription medications. This presentation will feature Ms. Georgina Perry and Ms. Liz Williams from Michigan State University Extension. And that will be on Wednesday, December 15th at 11 o'clock. So take care, have a great day, and have a wonderful Thanksgiving holiday. We'll see you next month.
Same to you, Sean. Take care, guys.
Take care, everyone.
Nice presentation, Mark. Thank you.
All right. Go green.